Sorry.
Good evening, everybody. Today is a webinar, is a very unique series of ICOG. It's a new series which has been started by ICOG chairperson Dr. Parul Kotlawala, and very interesting. The case I never forget. And here all the senior professors, surgeons who who are sharing their one case, two case, whichever is the one which is they found unique, and they want it. All the postgraduates and the delegates who are joining, obstetrician gynecologists, naturally will have those the glimpses of those rare cases, and will get their management seen and benefited. So, with these words, I want to invite Dr. Parul Kotlawala for his introduction. And Nilima, please put up the CV of Dr. Parul Kotlawala. Yeah. Dr. Parul is, and we know all, chairperson of ICOG, and he is endoscopic surgeon and consultant gynecologist. Dr. has been vice president of ISOPAM and chairperson medical education committee SEPOM. He is India coordinator of the new European Surgical Academy, India coordinator of International Adhesion Society, and has been vice president of FOXI, president of SOGOC, president AOGS, chairperson scientific committee AICOG 2017. Dr. Parul, I would request you to please address the...
Hello. I hope I am audible.
Yes.
Yes, sir. Yeah.
Thank you.
Yes.
Well, it is indeed a pleasure to be on this program. This program, I had an inkling of doing this after I listened to Dr. C.N. Purandare last year in a conference where he narrated one of his cases and how he, on telephonical guidance, his ex-student in dealing with a bad PPH case, and how patients survived because of that. That prompted me to think on this, and Dr. Purandare is going to present his case also subsequently. Today I received from Professor Dr. Shirish Daftari. He said that unfortunately almost all journals have stopped publishing case reports. And he said case reports also are a great learning situation. And it is nice that ICOG has taken up this project. So many times we have to deviate from the standard textbook management and protocols in an individual case. A person with experience and confidence within may deviate ultimately for the benefit of patient. See, most of the protocols are every individual case, and that is where a personal input comes in, and that is what is our intention, that how people have deviated. This just gives us an opening that we have to keep an open mind. In a given situation, one has to think out of box. And today we have a very excellent speaker and a senior guide for me personally, Professor Dr. Shyam Desai, who is also currently the president of South Asian Federation of OBGYN. So most, you can say, suitable person to present this webinar. Well, let us go ahead with it. Dr. Kiran, please take over.
Mike. You're muted.
You have to unmute yourself.
Yes. You're muted, madam. Muted.
Hello, am I audible now? Yeah, somehow.
Yeah, now audible.
Yeah,
Now
thank
only.
you, Dr. Parul, for very nice words. And really, this is a unique initiative which has been taken. I welcome all the experts, Dr. Mandakini, Dr. Alpesh, Dr. Harish Doshi, and of course our speaker, Dr. Shyam Desai, who is, they have all, Dr. Parag, they have joined very much. And Dr. Tank and Dr. Madhuri, I think I was actually checking this. So they have not been able to join. Dr. Madhuri is there or not? I don't find. So I would request Dr. Sarita, please invite Dr. Sheila Mane, our Vice Chairperson, to say a few words and address. And Nilima, please put up the CV of Dr. Sarita.
I think I'd like to, it gives me great pleasure to welcome
Dr.
Dr. Sheila.
Sarita, just let's, I mean,
Okay.
I know we all know you, but
Okay,
many of
sorry.
might not be knowing. So Dr. Sarita is the Secretary of ICOG presently, and she has been President of MOGS, Joint Secretary FOXY, and Quiz Committee Chairperson. She has been past Chapter Secretary of Indian Menopause Society, Mumbai, and past President of Mumbai branch, WWW. Sorry. So, Dr. Sarita, please address, invite Dr. Sheila Mane. Yes, Dr. Sheila Mane's CV is here.
Thank you, Dr. Kiran, for that kind introduction. And it gives me great pleasure to welcome you all to this program. I think this is really a unique series where we have a senior person share with us almost their lifetime experience in one, particular case where they could had a difficult time managing. It gives me great pleasure to introduce Dr. Sheila Mane, who's the ICOG Vice Chairperson. She's popularly known as the PPH lady, as she has done path-breaking work in the area of emergency obstetrics. She's currently DNB faculty at the KCG Hospital, Bangalore. She's also been the president of the Bangalore Menopause Society, president of the ISOPAP Society, Bangalore, and has held many prestigious positions in both national as well as international areas.
Thank you, Sarita. Thank you. Yeah, thank you. And once again, it gives me great pleasure. And today's topic is definitely very close to my heart. And I mean, all of us are really eagerly waiting to hear from Dr. Shyam Desai of the management of this case. And as Dr. Parul mentioned, that sometimes, our sixth sense or our experience, which we have to utilize to see that we do something and try to save the patient. And I'm sure all of us will be really gaining something from Dr. Shyam Desai's talk. And really happy to have this series as started by, as Sarita mentioned, by Dr. Parul. And we are having interesting cases here. So waiting to hear Dr. Shyam Desai, and I wish all the best for this today's program.
Thank you, Dr. Sheila, for your kind words and encouraging these us. And before I invite Dr. Shyam Desai for his case, I would just like to also welcome my co-convener, Dr. Vinita Singh. She has done so much. She's all involved very much into the organizing this program, and I will introduce her formally once I hand over her after the. So, Nilima, please put up the CV of Dr. Shyam Desai, sir.
So, thank you, Dr. Kiran. And I really feeling pleasure to be part of this program. Good evening to everyone. And last we had experienced such a wonderful program, first series of this, the case I will never forget. But before starting this program, I would like to ask Dr. Parag Bedewale, who is here, to say a few words and bless us because he is the chairperson-elect of ICOG. So Dr. Parag, please.
Thank you, Vinita. I think all of us are eager to listen to Dr. Shyam Desai. So let's not waste time in pleasantries. Our chairperson is already welcome. So let's learn from the interesting case that Dr. Shyam Desai is going to present. Thank you.
Yeah. Thank you, Dr. Parag. So, Nilima, please put up the CV of Dr. Shyam Desai.
Okay.
So today's speaker is Dr. Shyam V. Desai, sir. He is a towering personality, and at present he is President FOG, past President FOGSI, IAG in MOX, consultant OBGYN pelvic surgeon, and of Hinduja Healthcare Surgical Mother Care Nursing Home, and he is emeritus teacher, Wadia Maternity Hospital, Mumbai. As expert, we have three again very famous and renowned FOGSians. Dr. Alpesh Gandhi, I think sir has joined. Alpesh Gandhi, sir, yeah.
Yes,
So,
he's there.
Hi. Dr.
Dr.
Alpesh is
Alpesh,
here.
yeah. So Dr. Alpesh, sir, have you joined?
Yes, Dr. Vinita.
He's there.
He's
He's
here.
there.
Yes,
He's
sir.
here.
So
I've
Dr.
seen.
Alpesh Gandhi, we all know him because in the era of COVID, we had, started this webinar, and he did so much of work in his tenure when he was FOGSI president in the year 2020. He was vice president FOGSI in 2013 and governing council member of ICOG FOGSI in 2016 and 17. And he was also chairperson Practical Obstetrics Committee, past president Ahmedabad Obs and Gynae Society, past secretary Ahmedabad Obs and Gynae Society, convener, one of the most successful AICOG 2017, and so on. So,
You have already
yes, sir.
mentioned.
Yes, sir. So second, as expert, we have very sweet, my dear Dr. Mandakini Megh, madam. She was chairperson of ICOG FOGSI 2020 and 2021. International Vice President MWIA Central Asia and Vice President AMWI Central Council, National Vice President FOGSI 2012 to 2013, past President of Indian Federation of Ultrasound in Medicine and Biology. She is a great and a very sweet and a great academician. So welcome you, madam.
Thank you.
And third, we have Harish Doshi, sir. He is known as a great academician. And as designation, he is professor and head of the Department of Obs and Gynae, GCS Medical College, Ahmedabad, Gujarat, and teacher having experience of more than 37 years. He has published many books, faculty more than 250 times in national and international conferences, president of AOGS 2003 and president SOGOG 2004, organizing secretary for AICOG 2000, and chairperson Practical Obstetrics Committee, FOGSI 2004 to 2008. So welcome you, sir, as expert.
Thank you.
Now, I hand over the mic to Dr. Shyam V. Desai, sir, for his talk.
Thank you. Thank you. I'm indeed, can you see me and hear me?
Yes, sir.
Yeah. Okay. Thank you, Alpesh. Thank you, Harish Bhai. Thank you, Dr. Mandakini Megh, for agreeing to come as experts on this case that I'm presenting. It's the case of obstetric hemorrhage. Yeah, so we are accustomed to dealing with these problems day in and day out in our academic and scholarly adventures in our hospitals. And I'm sure we'll have a good discussion at the end of it. I thank the ICOG office bearers, Dr. Parul, Dr. Sarita Balerao, Dr. Parag Biniwale, and all the various people who have been responsible for putting this program, Dr. Vinita Singh, Dr. Pandey, Kiran Pandey, and I'm sure we will be having a good discussion at the end of it. So I think I'll start with the slide presentation, and as we go along, we'll develop a discussion. May I have the slide presentation, please? Dr. Nilima, Mrs. Nilima? Ah, yes, okay. So I congratulate Parul on having this web series that he has started. And when he asked me to present a case which made an impression on me, I had no hesitation in selecting a patient who was almost close to death, and we managed to make her survive with the help of our interventions. Now, I have been the vice chair of the ICOG in 2006 with Dr. Behram. Behram was the chairperson at that time. And we had several programs, but I feel now that the quality of the programs has certainly improved tremendously. And I congratulate all the present ICOG office bearers for that. Now, the case for discussion, in short, is a patient with massive postpartum hemorrhage. And she delivered in a satellite hospital in Mumbai 3 hours prior to be brought to our tertiary hospital as the Wadia Hospital. She was a multigravida, para 2, normal delivery. She had a slightly prolonged labor of around 18 hours. She'd had 2 previous deliveries which were not associated with any postpartum hemorrhage. This time she delivered a male child, 3.1 kilos. The patient had bled profusely. That's what the transfer note told us. And obviously the patient was white as a sheet and she was obviously in very great degree of shock. They had already started with IV at Pitocin 20 units at 10 o'clock in the morning. And this patient arrived almost 4 hours later to Wadi Hospital at 2 o'clock. Now, this patient was not really belonging to me. Had just finished my OT list and I was going home. And Dr. Ajit Mehta, who was the dean of the hospital at that time, said that, Shyam, you finished your work. There's a severe patient with severe PPH that has come in. The patient is my unit patient, but I'm not able to, do the procedure myself. I request you to please have a look at it and go ahead with an obstetric hysterectomy. I'm going ahead. I'm, giving you the entire. I'm taking the responsibility. Please go ahead, because this patient was really, really in a very bad state. The patient was restless. She had 3+ to 4+ pallor. She was gasping. Blood pressure was barely recordable. It was around 80/50. Pulse rate was 126 per minute. The patient was trickling blood per vaginum. The uterus was not firmly contracted. There was no, when we examined her in the receiving room, there was no genital trauma that we could associate, you could see. The bleeding was present. We did a quick collection of blood, the IV fluids were already going on. We started immediately with the large bore cannula. And as a result, we found that when the blood test reports were sent, we asked for the coagulation profile as well. It's not moving. Okay. Now, when you have a patient with hemorrhagic shock, if early shock, or we call it compensated shock, is when the blood loss is approximately 15 to about 30% of the blood volume. That is about 1,000 ml to 2,000 ml. The respiratory rate is around 20 to 30 per minute. The heart rate is 100 per minute. Blood pressure normal to mild increase is seen as a compensation initially. The patient is anxious. The urine output could be about 20 to 30 cc's per minute. So this is an early compensated shock. Now, when the patient bleeds a little more, then the blood loss is much more, about 30 to 40%. That is around 1,500 cc's to 2,000 cc's. The respiratory rate can go up. The heart rate is 120 to 140 per minute. The blood pressure shows a profound fall. It could be less than 70 millimeters of mercury systolic. The patient is restless, lethargic, confused, and the urine output may be barely present, less than 15 ml per hour. So these are the two types of shock that we come across. Now, what are the risk factors for a postpartum hemorrhage? And we all know that in a patient with multiple pregnancy, twins, or preeclampsia, a history of previous postpartum hemorrhage, prolonged labor for more than 12 hours, the maternal age more than 35, general anesthesia being administered for, say, a section, obesity, chorioamnionitis are all factors which can influence the occurrence of postpartum hemorrhage. Now, in addition to that, if there's a patient with a previous C-section, forceps or a vacuum has been carried out, placental abruption, placenta previa are again factors which can precipitate postpartum hemorrhage. Sometimes there's a cotyledon of the placenta that is retained that can prevent the uterus from contracting properly. And whenever there's a large baby more than 4 kilos, they say that this patient is very likely a candidate for postpartum hemorrhage. Now, the initial treatment that we have all been advocating and we've been following is that you carry out certain initial steps for postpartum hemorrhage. You call for help. You start an IV fluid, crystalloids, given now tranexamic acid, that is what is advised, 1 gram in 100 ml of saline slowly. You carry out uterine massage, give uterotonics. WHO recommends the administration of 10 units of Pitocin, but you could also give misoprostol, you could give carbetocin. And the next step of interventions is you give aortic compression, bimanual uterine massage, the NSG garment can be applied, and uterine tamponade. So these are all steps which are almost at the back of our minds, and in the textbooks, you recognize them extremely well. Now, if you find that this patient has, even a call to the labor room and they said that this patient is bleeding, the first thing you look for is that uterus contracted, or is it loose, or is it atonic? If there's a retained placenta, you deliver that placenta, you resuscitate the patient, you find out the exact reason for the underlying cause. It may be traumatic, it may be atraumatic. If it is traumatic, then you obviously have to suture whatever is damaged. If it is atonic postpartum hemorrhage, you start oxytocin, do the massaging, etc. So the initial management for excessive blood loss is targeted towards the most common cause. Next slide. Okay, I think they are changing it in the office, is it? Okay, then I will not change it. Now, we are talking about surgery, and this is why the discussion today has been on this case. When should the decision to take a surgical opinion be decided upon? And how should you take this decision? The use of pharmacological agents should not delay recourse to surgery. If you feel that these uterotonics and the massage, etc., the simple steps that one takes are not producing results, it is better to take a surgical option earlier rather than later. And once a decision is made to embark on surgical hemostasis, the most appropriate choice of procedure will depend in part on the experience and expertise of the available staff. So you have to gather all the people who are around you, and you have obviously had some sort of a training that you have given them on this PPH drill, and you try and get them to help you to carry out whatever course of action you want to take. Surgery, I can reiterate, is not a first choice, but surgery can be life-saving. All obstetricians should have the skills to deal with a surgical intervention. I will go to these various interventions one by one. Next slide, please. Now, what are the surgical options available? As we had mentioned earlier, bimanual compression, aortic compression, uterine packing, tamponade, the use of compression sutures, stepwise devascularization, and finally, hysterectomy. Now, it has often been said that the number of obstetric hysterectomies that are carried out in a particular center would give you some idea of the obstetric care that is being offered at this center. The more the obstetric hysterectomies is obviously, it's not a very good thing that you have to resort to an obstetric hysterectomy. But if it is a tertiary center, sometimes you get these moribund patients, and sometimes you have to have a hysterectomy. Now, next slide, please. So a diagram to show that if there is a retained placenta and for some reason the uterus is not contracting, with the help of either cord traction or with the help of a manual removal of the placenta, one must take that placenta out, because that is what is preventing the uterus from contracting. Next slide. Bimanual compression is again another very, very useful step. You put your whole hand or fist inside and compress the uterus with the abdominal hand. And with this, if you maintain this particular position for some time, the uterus will eventually contract and the bleeding will stop. Of course, this is one of the earliest steps that one takes. Next slide. Now, sometimes elevation of the uterus with the fist in the vagina is extremely useful. It leads to angulation and kinking of the uterine vessels, and again reduces the amount of blood that goes to the raw surface of the vagina, of the uterus. Compression, anteversion, and massaging over the elevated uterus is also very useful. Now, earlier they used to carry out douching and packing, and now we do not really resort to these. There's also been described an umbrella pack that has been used. You put in a gauze piece, put in a lot of either gauze pieces or cotton wool, and then you into the uterine cavity, and give traction on it so that the bleeders are, or rather the blood vessels are compressed in the pelvis, and the bleeding can come to an end. Now, whenever there's a bleeding from a tightly contracted uterus, one should obviously suspect the diagnosis of trauma to the lower segment of the uterus, or the cervix. So remember, this is something which we teach our undergraduates and is an extremely useful method, so that when there's a patient of PPH, just put your hand on the abdomen. If the uterus is lax, it is atonic. If the uterus is contracted, then you're obviously dealing with a traumatic cause of the PPH. Next slide. Now, aortic compression is something which is also very useful. It's temporary but effective to allow time for resuscitation to catch up with the volume replacement and the appropriate surgical, till the appropriate surgical support arrives. So till you get all your people around you, just compress the uterus, compress the aorta against the spine, and you will find that the chances of bleeding, or rather the incidence of bleeding, becomes much less. The judgment of senior clinicians, taking into account the individual woman's future reproductive. And by this, they mean that if the patient is a primea gravida, you are less, or rather you are more reluctant to do a hysterectomy. Whereas if she has had 2 or 3 children, you immediately say that, well, I think this patient would be far better off with the uterus removed. Next slide. Tamponade, and this is something which has now really caught on, because various types of tamponade are available. You could have the actual balloon tamponade that has been is now available in the market. But earlier we used to have the condom catheter, which was the entire condom was placed into the uterine cavity, and the condom was attached to a Foley's catheter. The saline was instilled through the Foley's catheter, and as the saline or 5% glucose went into the uterine cavity, the catheter, the condom expanded and pressed against the raw surface in the uterus and brought about hemostasis. And you kept it in there for some time. Then gradually, over a period of hours, you slowly tried to reduce the amount of fluid in that condom or the balloon, and you gradually found that with the catheter, the condom and the catheter jointly come out, you find that the bleeding is well under control. So these are something which is really useful, and you can do it immediately without resorting to a laparotomy. So this is something which I think all of us should be extremely well experienced with, to bring about this particular tamponade of the uterine cavity. And it should be remembered that all these various methods are initial methods, and hysterectomy should not be delayed until the woman is in extremis, or while less definitive procedures in which the surgeon has little experience are attempted. So do not waste too much time on this. When you carry out these various procedures, you would know immediately what the response to your treatment is. Next slide. So this is a diagram of the balloon that is now available, and you can inflate the balloon and make sure it's kept inside the uterine cavity, and then you increase the amount of fluid in the balloon, and as this increases, the uterus contracts upon it, and the bleeding becomes much less. Next slide. Now, so there is a test which is called as the tamponade test. There is a positive test, that is control of PPH following inflation of the balloon, indicates that laparotomy is not necessary, whereas a negative test, that means continued bleeding following inflation of the balloon, is an indication to proceed to laparotomy. Next slide. Now, the success of balloon tamponade approximately is about 84.9%. When it is combined with additional surgical interventions, compression, sutures, and stepwise devascularization, they said that the overall success can be increased up to 98.1%, which is a very, very good figure. Next slide. Now, we all know that the various hemostatic sutures that have been devised. And in all our PPH workshops, we have been showing them. Dr. Sheila Mane has been, and Dr. Preeti Kumar have been quite active in conducting these workshops. And even for the SAFOG, we are conducting workshops which are appreciated by all the other various nations around us. So the best known version, which was described by Dr. B. Lynch, and Christopher B. Lynch had come to Bangalore, and we had interacted with him in 1997. That is quite a long time back. It requires a hysterotomy. So this is a suture that is usually carried out when there is a cesarean section, and you find that the cesarean section, that the uterus is flabby, and you require a little more tone to it. And that is when you carry out the insertion of these sutures. And in 2002, that is almost 5 years later, Heyman described a modified compression suture which does not require a hysterotomy. In 2007, Ghezi et al. Reported success in 10 out of 11 women managed with the Heyman suture, for example. Yu et al. Described success in all the patients on whom they use a simple technique of vertical compression sutures. And Kafali et al. Described success in the women that they treated using a variant designed to control bleeding of cervical origin. Next slide. So now, a report from the Scottish Confidential Audit of Severe Maternal Morbidity identified 52 cases where hemostatic sutures were used for the management of major PPH. Hysterectomy was averted in almost 81% of the women. Again, this success rate is of the same order as that reported in other case series. These observational data suggest that hemostatic sutures are effective in controlling severe PPH and reducing the need for hysterectomy. So when the patient is not in very severe shock, you can try and go ahead with these sutures and see whether you are able to control it. Next slide. Now, stepwise devascularization obviously requires a laparotomy. And for that, you have to have an anesthetist on hand. You have to have the patient in a situation where anesthesia can be given. And O'Leary method, the uterine artery is ligated approximately 2 to 3 centimeters below the incision, which we take for a C-section. And Dr. Ajit Rawal has also, had a similar suture being taken, of course, with a slightly different, variation. And that has also was very extremely, effective. You also have to ligate the ovarian artery at the junction of the infundibulopelvic ligament and the ovary. The vaginal artery, the descending branch, has also to be taken. And they say that this stepwise devascularization gives a success of around 80%. Next slide. So this is a diagrammatic sketch showing how the uterine artery can be ligated, the descending cervical branch can be ligated, and of course the ovarian artery through which collateral circulation is given to the uterus is also to be ligated. So when you devascularize all this, obviously the raw surface in the uterus receives less blood supply. Next slide. Now, internal iliac artery ligation is something that every obstetrician should know, because this internal iliac artery ligation can be really life-saving. A recent case series described 84 women with PPH from various causes who underwent internal iliac artery ligation, and they found that hysterectomy was required in only 39% of them. So it means almost 60% of women benefited from internal iliac artery ligation. We all know that this reduces the pulse pressure, and as a result, the blood has a chance of clotting. A follow-up study of 45 women suggested that internal iliac artery ligation does not impair subsequent fertility and pregnancy outcomes. So this was something which one feared, saying that their reproductive potential would subsequently deteriorate. Next slide. From our own country, we have Mukherjee et al., and they performed 36 cases of internal iliac artery ligation, a success rate of as high as 83.3% in 6 years. Joshi et al. Did a study on 110 women who had undergone bilateral internal iliac artery ligation over 13 years with a uterine salvage rate of 60%. It's very good results. And one must obviously impress on our postgraduates that it is important to do a bilateral internal iliac artery ligation. There's no point in doing a unilateral one because it has to be, the supply has to be stopped from both sides. Next slide. So this is a diagrammatic sketch where you identify the common iliac and the bifurcation. And remember, the anterior division is seen very clearly. The posterior division goes backwards and is not seen. So you pick up the mixture and take only the uterine artery. You need not use a non-absorbable suture. You can even use Vicryl for this particular step. All that one has to reduce is the blood flow to the internal iliac artery and obviously subsequently to the uterine artery. Next slide. Now, the lack of comparative studies tells us that it is impossible to assess which of the various surgical hemostatic techniques is the most effective. We don't have any comparison between the sutures, the B-length sutures, or the internal iliac artery ligation. So therefore, the available observational data suggests that balloon tamponade and hemostatic suturing than internal iliac artery ligation, and they are questionably easier to perform. So if you are able to put in that balloon tamponade, or if you are able to do that hemostatic suturing, you can go ahead and be assured that more or less you will have a good outcome. Next slide. Now, if in a center which has a good radiology department, you can have selective arterial occlusion or embolization by interventional radiology. And there's something like a 97% success rate with arterial embolization for obstetric hemorrhage that has been quoted. The RCOG Green Top guidelines tell us that in almost all their cases, the entire group of cases were successful when they were tackled with this arterial embolization. And hysterectomy was averted in almost 70% of cases. Next slide. So then you have situations where like this way, there's a prolonged labor, the patient is delivered vaginally, she keeps pouring out blood. And then you have a situation where the uterus has a trauma, there's a broad ligament hematoma, there is a bleeding from the uterine artery. And then you obviously have a situation where your sutures are not going to help. And neither is your internal iliac artery ligation also going to help. And you come to the next step. Next slide. And then you have to carry out what is known as an obstetric hysterectomy. Now, the decision for hysterectomy should be made by an experienced consultant, and the decision preferably being discussed with a second experienced consultant. The procedure should be carried out by a surgeon who's experienced in carrying out the hysterectomy. I mean, he should have been a fairly well-trained surgeon. Our patient, the one we discussed, was subjected to an obstetric hysterectomy. And I'll tell you what the reasons. Even in modern obstetrics, it has a major life-saving role in certain situations. Next slide. Now, the concept of obstetric hysterectomy was thought of in the 1800s. So there was this Cavallani from Florence who identified the concept of this hysterectomy. In 1868, Horatio Robinson Storer from Boston documented obstetric hysterectomy in a patient with a large tumor which was obstructing the delivery of the fetus with cauterization of the stump being carried out. Godson and Lawson Tate have devised refinements. Next slide. In 1876, and that is when things really picked up, Porro devised the concept of subtotal hysterectomy. So there's no need to remove the entire uterus, and the patient survived the operation. 1880, Robert Harris reported 50 cases from 7 countries, the mortality rate of around 60%. In 1938, again, extensive experience in a charity hospital in New Orleans gave us a little more confidence in carrying out, give them more confidence in carrying out this operation. And in 1951, Davis from Chicago, 20% of C-section hysterectomy rate in 736 operations. And then the operation was obviously well accepted. Next slide. Now, the incidence of obstetric hysterectomy varies from developing countries and developed countries. In developing countries, Pakistan, India, Nepal, the incidence could be between 40 to 70 per 1,000 deliveries. That is quite high. And in India, we found that the incidence varies from 4% to 40%, depending on whether it's carried out in the urban, studies carried out in the urban areas or whether it's carried out in the rural areas. And Banale et al. Said that that was the incidence that we had. In developed countries, the incidence is much less, 0.2 to 1.6 per 1,000 deliveries, and 1 in 6,978 in Japan. In Canada, the incidence is approximately 53 per 100,000 deliveries, or that is around 0.5 per 1,000 deliveries. So we have a very much lower incidence in the Western countries. Next slide. The labors are better supervised. They have other methods to resuscitate the patient. So therefore, in the developed countries, it is much less. Now, what are the three main causes of hysterectomies? One is atonic postpartum hemorrhage, which we all know. placenta accreta is becoming an increasingly common problem thanks to the increased incidence of C-sections, and prenatal diagnosis usually is available now with so many ultrasound examinations done for our obstetric patients. So you can counsel the patient, you can devise the treatment of these women, and cesarean hysterectomy is preferably the preferred treatment rather than trying to separate the placenta from the uterus. In the modern era, thank God for good antibiotics. Fortunately, infective pathology is a rare occurrence, but otherwise, severely infected uteri were subjected to obstetric hysterectomy. Next slide. Now, when you have to think of an obstetric hysterectomy, you have to think of the parity. And of course, the decision is easier in multipara, as we had stressed earlier. The decision should be taken in good time before the condition deteriorates. All other measures to control pathology should be taken well in time. And as also to make sure that the patient is not in DIC, because sometimes these patients in a prolonged state of shock can sometimes develop DIC, which can be very detrimental when you take on a surgical procedure. All resuscitative measures, IV fluids, blood transfusion, and facilities, along with antibiotics, should be done by a team of well-trained medical professionals. Next slide. Now, the various points, my important points in this particular discussion are the timing of the decision is crucial. There's no point in taking this decision too early when you could otherwise have tried all the other measures, or taking it too late when the patient is in irreversible shock, and whatever surgical expertise that you have cannot save a patient who's in irreversible shock, even if he carries out the hysterectomy. Exclude DIC, as I said. Multi-speciality approach is required. You have to have physicians, you have to have intensivists, good anesthetists. And in spite of all this, sometimes the mortality can be as high as 10%. Next slide. So the technique, and a few slides on the technique, surgical principles, similar steps as to an abdominal hysterectomy. Your abdominal entry could be either phalansteal or vertical midline, whichever you prefer. Uterine ovarian vessels markedly enlarged and distended. So you might have to take sometimes two ligatures on these vessels. And the adjacent tissues are often very friable and also edematous. I've had a situation where we did an obstetric hysterectomy for a very patient with PPH, and we carried out the hysterectomy, and within 2 hours, we found that there was welling up of the blood again in the peritoneal cavity. And one of those sutures had become loose, not because of our inadequate suturing, but the edema around that particular vessel had decreased, and as a result, that suture had proved to be ineffective. And therefore, sometimes make sure that you take 2 or 3 stitches necessary, or make sure that you isolate that uterine blood vessel and take a separate stitch on the blood vessel itself. So these are some things which you learn as you go along. Next slide. Eventrate the uterus, because that immediately reduces the amount of blood flow. Immediate arrest of hemorrhage necessary. You can carry out with green Armitage forceps, sponge holders, and in cases of uterine trauma or rupture. Compress the adnexate to reduce collateral blood flow. And the uterine vessels may be also compressed with the tourniquet. Next slide. Doubly clamp and tie the pedicles. It may be necessary to do a subtotal if the parametrial vessels are not involved. That means there's no bleeding in the lower segment of the part of the uterus. You can get away with a subtotal, but you should ideally try to do a total. In cases of placenta previa accreta, it is a total extirpation is necessary. Avoid trauma to the ureters by applying clamps medial to the uterine stumps, as we do in an abdominal hysterectomy. Next slide. Identification of the cervix may be difficult as it is unduly stretched. An incision of the lower segment can be used to trace the rim digitally. In a previous cesarean section, adhesions may require sharp dissection. Check the integrity of the bladder post-hysterectomy, especially in placenta accreta, and you may use methylene blue to distend the bladder if necessary. Next slide. Now, as I said, that our patient underwent obstetric hysterectomy. She withstood anesthesia well, the surgical procedure well. The post-operative period was uneventful. We transferred 6 bottles of blood and 2 packed cells. In the days before, we used to give the separate, fresh frozen plasma, etc. They were almost something like 15 or 20 years ago. The patient was followed up for 3 months subsequently. Next slide. Now, this particular publication comes from the Aurangabad Government Medical Hospital. And I know personally many of these people, Dr. Kalyankar, Dr. Gadappa, they are all, I have interacted with them through Foxy. Out of the 43,000 confinements, 55 cases underwent obstetric hysterectomy, giving an incidence of around 0.13%. The incidence following vaginal delivery was 0.05 and following cesarean section was 0.3. So the incidence of obstetric hysterectomy at cesarean section is much more than with the incidence at vaginal deliveries. The most common indication was morbidly adherent placenta in 50% of cases, but followed they had 36% of uterine atony and rupture of the uterus in 14%. In their case, in their study, the maternal mortality was approximately 9.09%. And as I told you, that the mortality can be quite high in these patients. Not only are they in shock, not only technically is the procedure more difficult, but these patients with obstetric hysterectomy have a much higher maternal mortality. Next slide. Now, this particular publication comes from the United States in the ACOG Journal 2011. And the objective was to perform a population-based analysis to examine the morbidity and mortality of peripartum hysterectomy in comparison with non-obstetric hysterectomy. So data from the nationwide inpatient sample were used to compare peripartum and non-obstetric hysterectomy in women less than 50 years of age. Next slide. A total of almost 5,000 women underwent peripartum hysterectomy with had a non-obstetric hysterectomy were identified. That means they compared the two groups, peripartum and non-obstetric. And they compared the morbidity, and they found that the bladder and ureteral injuries were more common for peripartal hysterectomy, which is understandable because the anatomy is distorted in a woman who is an obstetric patient. There were no differences in the rates of intestinal or vascular injuries between peripartum and non-obstetric hysterectomies. The rates of reoperation were much higher in a patient with an obstetric hysterectomy as compared to a non-obstetric hysterectomy. Post-operative hemorrhage, 5% as compared to 2%. Wound complications, 10% as compared to 3%. And thromboembolism was also more or less higher in the obstetric patient because of probably the higher levels of fibrinogen that were present. Next slide. They concluded that the peripartum hysterectomy is accompanied by substantial morbidity and mortality compared to non-obstetric hysterectomy. The procedure is associated with increased rates of both intraoperative and postoperative complications. And the mortality of peripartum hysterectomy is more than 25 times that of a hysterectomy performed for a gynecological cause. So this is something which one has to realize when one is taking on the step of a hysterectomy. Next slide. Now, this particular case discussion that I selected was, it highlights several points. One, it is important in a tertiary center like say Wadia Hospital or KEM Hospital or government hospital in Ahmedabad or anywhere in the world, in the country, to be ready and equipped for obstetric intervention at all times. One team which is ready at any time, because suddenly you may have a patient being wheeled in from the periphery, a very extremely moribund state. It's not that the patient is delivered in that hospital. She comes in a state which is extremely in extremis. The decision to perform a surgical intervention should be taken in good time. Now, the operation that we carried out, the patient was brought to the Wadia Hospital, and within 1 hour, the patient was on the operation table. And within an hour and 45 minutes, the patient's operation was over and she was being wheeled back into the ICU. So therefore, it is important to take a quick decision, have a good team of experts ready to tackle the situation. You must have a good blood bank to give you the necessary blood and blood products, and good anesthetists who are willing to take the charge of the situation and say, you go ahead from your side, we are handling this situation from our side. Round-the-clock availability of anesthetists is essential, and the decision to perform obstetric hysterectomy should be taken in good time. There's no time to dilly-dally and trying to compress the uterus and trying to take some sutures and then do an internal iliac artery ligation, and then finally line it up with a obstetric hysterectomy. That entire hysterectomy, the surgical steps were carried out in less than 15 minutes. And that made all the difference because the patient was immediately found to be improving with every minute that went past that. Next slide. This is something which tells us the various symptoms and of shock, which I think I have already discussed this earlier. And I think I end my talk with this, the last slide, saying that, well, a timely intervention is most important. Thank you so much. Banda kara.
Thank you, sir. It was a wonderful presentation. And I think before going for obstetric hysterectomy, we should do all the steps to save the uterus. But I think finally, if we are not able to save the uterus, save the life of mother is very important. And I think there is increasing rate of PPH nowadays because of increasing incidence of cesarean section and having PAS. So that is the reason why the incidence of PPH has been increased from 35 to 38%. So now we have three experts, Alpesh sir, Mandakini Megh ma'am, and Harish Doshi sir. So over to you, sir, for interactive, for your expert comment.
Vasomotor symptoms.
Sir, very good, a very good case, and so many things to be learned from this case. And first of all, congratulations to you for you could save a woman who is nearly dying. At the same time, severe PPH, as Dr. Vinita has mentioned, severe PPH incidence increases in spite of having so many potent iterotonics available and in spite of so many surgical techniques available. Maybe because of increased incidence of previous cesarean section, maybe increased incidence of obesity, ART pregnancy, just GDM, HDP, all these incidence is increasing. Maybe because of all these things, incidence is increasing. So you have you rightly mentioned that we need to keep our setup ready, as you have mentioned, to keep the setup ready of tertiary care center. I would also like to say we need to keep setup. We all small setup or a tertiary care setup or those who are practicing in the rural all need to keep their setup ready. Whatever they can keep at their place, we need to be ready with all these things because it can happen to any patient at any time. And it's of course, sir, you are a very skilled person, very experienced person. You are working at tertiary care center, but at the same time, those who are working at periphery or rural setup, they also need what they should do at the beginning, as sir has mentioned, to identify high risk patients, high risk factors for the PPH, to do counseling, and during they should also try to control blood pressure, blood sugar level. They should try to keep hemoglobin level 11%. All these things care should be taken during the antenatal period, and when she is in labor, to keep setup ready, to keep blood ready, cross-match blood ready. Of course, sir has mentioned, take IV lines with a wide bore needle, and at this, it is also important to identify approximate amount of blood loss. And as sir has mentioned, the different grade of shock, 1, 2, 3, 4. So when she is having massive hemorrhage, as sir has mentioned, do not allow her BP to fall and manage her as the massive transfusion protocol. And as per the protocol, basic principle is manage hemorrhage vigorously, and begin resuscitation with blood component as earliest as possible. Particularly those who are practicing in rural area, here we could know that even the patient, I think patient transfer from one place to another in Mumbai, it took 4 hours. And I think it's a golden hours. These all are the golden hours. So those who are practicing in rural area, it is always to keep transportation facility ready, to identify the center ready, to keep cross-match blood ready, to accompanying the patient. and wherever, and of course during transportation or before that, cannula and balloon and anti-pneumatic garment, all these are very, very helpful. And particularly I have experience of CHOS, which are also, it is also very useful, particularly when bleeding is from the lower segment, it may be helpful. And those who are working in periphery, if blood is available, if components are available or storage facility is there, while when we are shifting the patient to the tertiary care center where Dr. Shyam Desai, like very experienced surgeons are working, but at the same time we should look that patient reaches there in a good shape so that they can manage the patient. Otherwise, it will be difficult. So when patient dies because of PPH, usually patient does not die because of PPH, but patient dies because of hypofibrinogenemia. And if we can give cryoprecipitate for the transportation facility, we need 20-25 minutes to arrange the transportation, counseling, to write a referral letter, everything. So in this 20-25 minutes also we can give 3-4 cryoprecipitate, which will help the patient to reach a tertiary care center in a good position. Of course, during those days, as sir has mentioned, components were not available, but now we are fortunate that all these components are available. And conservative management, of course, this is a life-saving procedure, and in any patient, anytime we may need to treat her if she is having severe PPH and is not controlling, we have to go with this is the procedure of obstetric hysterectomy. But now conservative management, many patients are not ready and they want to preserve their uterus. So in all these situations, particularly we have some conservative management, and particularly now we have one more armamentarium in our hand, that is recombinant factor 7A. During those days, even component were not available and this was not available. But of course, this is also one which we can use during this modern time, modern obstetric. And probably we may save with the use of recombinant factor 7A, we may reduce the number of blood units, and even sometimes we may even preserve the uterus. It is not only life-saving, but it can also be a uterus preserving drug also. And I would like to, at the end, would like to share my personal experience. In one case, I had to, again, before 20 years, I had to undergo obstetric hysterectomy. After 4 or 5 months, a mob with relative and patient and 15-20 relatives came to my hospital, and they started fighting with me that you were telling you did hysterectomy, but now she has started menstruation. I was surprised, and then I came to know that the patient was saying, I checked the file and I came to know, I have mentioned that it was a unicornuate uterus and it was removed. But at the end, actually, it was a uterus didelphylus. And a second small uterus, which was not identified at that time, was missed because one uterus was very big. And this was far away from this. So this was my experience. So I think when we are managing obstetric hysterectomy, and if this patient is having any uterine anomaly, good to also look for other uterus is there or not, or other any anomaly is there or not. Very good lesson we could learn from this case. Once again, congratulations for the nice presentation and nicely managed.
What is that this patient delivered in a maternity home, which is less than 2 miles from Wadi Hospital. But the delay was in recognition that this patient is bleeding by the medical officer, and the decision to say that, well, she requires more treatment. So that was the lag which could also have been reduced if they had found that she was bleeding immediately within an hour or so, immediately transfer. But they did not transfer.
Yeah, delay should not be there. Delay is one of the very important things.
Delay sometimes kills the patient.
Yes. And now, sir, fibrinogen are also available. So many new things are now available.
Now there is a definite advantage because factor 7 is available, cryoprecipitate, various blood components. But in those days, it was not that easy. So we had to give fresh blood rather than the crystalloids only. But the delay has to be taken care of.
Yes.
Recognition.
it was exhausted. I think you have mentioned 14 hours and then delay.
Dr. Manish Pandya wants to say a few words, I think.
Namaskar,
Yes,
sir.
Dr. Manish. Yeah.
Namaskar, sir.
Namaskar.
First of all, congratulations on the base of SFOG. You are doing wonderful thing, and you are my mentor who had make me faculty, sir. Pranam, sir.
Thank you.
Sir, in our armamentarium, we have got one Como Gemji suture designed by our own Mahesh Gupta. And I had done 500 cases study in medical college. And it serves both the purpose, uterine compression as well as uterine artery occlusion. So it is also one of the life-saving technique that we can incorporate in stepwise devascularization. And it also gives very good result if we do bilateral Como Gemji suturing with, it gives just compression, just like B-Lynch, and it will give occlusion just like O'Leary. So it serves both the purpose. So I think it is also one of the good things. And all the best to Gaurav for his endoscopy endeavor. Thank you very much, sir, for giving me opportunity.
Okay.
Manish, 500
Yes, sir.
cases.
Yes,
Where
sir.
did you get so many in PPH?
No, sir. No, sir. Now, Parul, sir,
Yeah.
it is not all the cases of PPH. It is the cases of previous 3
Then-
CS, previous 2 CS, placenta previa.
So why do
So
you
it's lies
want
in
to
almost
use compression suture? Why do
Why
you
in
use
all cases?
compression
What?
suture?
Is it prophylactic?
It is a prophylactic and sometimes it is therapeutic also. Because in PPH cases, we get very good result. I was supposed to initiate this query because this was done in medical college. Every day, we have got 5 to 10 cesarean section in our college. So it is a not big issue to do 500 cases for a one resident for her dissertation. And in this type, all the cases in prevention, prophylactic also we had used. And we had used in cases of atonic PPH also. And we found little bit good result. It is not that it is 100%, but it is also one of the suturing techniques designed by our own person, and it gives two important component of atonic PPH. One is compression, and second is uterine artery occlusion. And if we need it, we can take this just like chaw stitches in the lower uterine segment, when particularly in the cases of placenta previa, we are putting one dilator into the cervical canal, and on both the side of paracervical region, we are taking the chaw-like stitches, and it also serves purpose of compression as well as occlusion. So it is also very good technique, just I am mentioning, and I am happy with this technique because in medical college, we are using this routinely, particularly when we think that this patient can go for PPH, particularly in the cases of severe PIH, placenta previa, previous 3 cesarean section, big baby, twin or triplet cesarean section, and we are happy, Alpesh bhai. This is just my observation. Just I want to share it. Hello.
We have 3 experts. We would like to have their comment
Yes,
and
yes.
Dr. Shyam also.
Yes,
Because
yes,
I
yes.
think this is an overkill. I mean,
Uterine artery
prophylaxis.
Parul, by uterine artery prophylactic, ligation of uterine artery is somewhere mentioned in some textbook, but I have never seen prophylactic compression suture. I have never.
Dr.
Alpesh bhai,
Mandakini wants
AC Rawal has used this uterine artery by his own technique in so many cesarean sections.
No, uterine
So
artery
he
is
used
there.
to-
Uterine artery, dear Manish, uterine artery
Yeah.
prophylactic is always there. It is
But
there in the
compression,
textbook.
but when we are thinking of a big baby, twin pregnancy, or PIH, in which cases, if we suspect that this patient can go for PPH, then it is better to do, and it has got no harm. We had done repeat cesarean section of the same patient, and we found there is nothing else because this suture
Dr.
will
Parul
absorb within.
Dr. Parul bhai, Shyam Desai, Dr. Haresh bhai, all other expert, Dr. Sheila
Dr.
Mani, all are
Mandakini
here.
is
I
also
also-
here.
Can I come in? Can I come in?
Mandakini madam.
Yes, yes.
For me, then you. So,
Yes, madam. Namaskar, madam.
Namaste. So, good evening, everyone, and it's such a pleasure to be here again at the ICUG platform, and seeing a new activity is a real pleasure. So, congratulations, Dr. Parul, for this. Never forget. And I think working together with Alpesh bhai, Parul, and Parag, we will never forget. That is also one of the series. Now, coming back to the case, here I would like to have few comments, including some government policies which are now reducing the, obstetric hysterectomy totally. First is at the tertiary level. And I was fortunate to actually work in Kama Hospital and all the district hospital where the tertiary cases, we were getting lot of rupture uterus and all the complicated cases. Okay. So here, what is very important, which I just want to mention, is an obstetric drill, where we all in the labor room and other places, we mention, so many times we mention only in theory, but in practical, in the labor room, with the junior most to the senior most assistant and the IABIs and everybody, we used to take a obstetric drill and, allow them to have the instruments ready, drugs ready, everything was. So that actually reduced your timing of, rushing up and, not messing up at the time. That is very important. And I always call it, in order to have the peace, you have to prepare for the war. So we are all the time preparing for the war if some cases comes. And I think in my total, my obstetric experience at various institute where I was heading, around I have seen 78 cases of rupture uterus, and we have managed many cases except the few mortalities. So that is very, very important. So to reduce this kind of obstetric trauma, PPH, government has taken many policies, and we are aware that we have reduced maternal mortality in India, especially in 2 states, very well we could control. And I think WHO and everybody is appreciating. Why? Because Dr. Shyam Desai will appreciate when he was Secretary General, that emergency obstetric care, I was Deputy Director that time, emergency EMOC training was a great training. Dr. Shyam Desai, you remember that?
Yes.
And government of India, Maharashtra.
EMOC.
Yeah. So that EMOC itself was identification of the, risk factors, high risk pregnancies, any obstacle, just identifying in time and doing whatever procedures Dr. Desai has described, or taking the preventive measures was very major. And around 600 medical officers, MBBS level, they were not MD of course, they were trained, and in the process, they got trained. And so many are doing the cesarean section because we taught them cesarean sections also in the 3 months. So Dr. Desai is very much aware of that. I think he was a part of it when Sadhana Desai madam was it. We have not left it. We have also trained the BMOC. BMOC is the below the doctors, like nurses, staff nurses and other people, where they have to immediately identify, report to the EMOC person or the medical officer and shift. So the total period of identifying, treating, finding out the medicine, everything was reduced. Second was a supply of medicine, huge supply. As even I remember in Kama Hospital that time we had a blood bank, we had factor 8. I myself was giving cryopresis that time also, around 20-25 years back. So that has also improved at the government level. And the last but not the least is a continuous training. You can see there is a continuous training, and speakers or experts like us and all of us are training at somewhere. And internal iliac ligation, especially you can see in the cadaver, I can see Amravati level, they are doing lots of, training for the internal iliac ligation, and so many things are going on, which is actually reducing the this obstetric hysterectomy level. And third and the last point, which is very important, is economic status. Dr. Shyam Desai has actually mentioned that in third world countries, it means there is a Cochrane review I recently read that, in Cochrane review, if the economic status is, low, then there are higher chances of obstetric hysterectomy. So what it means is there should be a very good ANC care at the government level where the government funding is there. And now at every level, we have high risk clinics. We have, high risk, identified medical officer. They in time, and there are huge data maintained by the Anganwadi workers, ANM, ASHA, etc. And overall policy is reducing the obstetric hysterectomy due to the PPS. So with these words, I think, thank you very much for giving me the opportunity, Dr. Shyam Desai, and all the convener and the ICOG chair and everyone. Thank you very much.
Hello.
Harish.
Yeah, thank you, madam. It was a good, experience to share with us. Now, I would like to ask Dr. Harish Doshi, sir, for his expert comment.
I am last. Patient is now in irreversible condition. I have to do hysterectomy only. I must thank first the President Secretary Foxy and President Secretary ICOG and the whole team of ICOG for giving me this honor to chair the session of Dr. Shyam Desai. Vinita madam, I am going back to the beginning of webinar. You introduced Shyam Desai in a very small, CV. He is an international stalwart faculty and is like elder brother to me. I am knowing him since last 25 years, and all through my Foxy career, he has helped me. He has helped every Foxy. Still, he is a down-to-earth personality, a great virtue of a gynecologist. Naturally, as Parul mentioned that we encounter this and sometimes in emergency, we have to deviate from the textbook. Shyam Desai, like faculty, is a textbook himself, right? You cannot. Still, the subject is very well covered by the
sir.
sir.
I do agree with you, sir. 20 years back, when I was Joint Secretary of Boxcon in Patna, and Shyam Desai, sir, he was chief guest in that conference. He came and he presented me a book of laparoscopy, sir. If you can remember, he said, Vinita, you will be go on a height. So, sir is such a humble person, such a, I can't express my feeling for him.
Myself and Parul have taken at Vadia training for endoscopy surgery under Dr. Shyam Desai. Well,
even I have
comment on the subject, right? One thing now, I am very fond of using carbetocin. It is a very good drug for prevention.
Yes.
See, for PPH, we call 3: prevention, pressure, and pray. Pray to God, right? Vessel occlusion is always there, but prevention, most important. Pressure, most important. Anywhere you give pressure, inside negative pressure, there is suction cannula nowadays very well. Outside compression pressure, bimanual. Sir has nicely mentioned bimanual and aortic, right? Compression. All this pressure gives you time and sometimes it is curative also. So that is and time and again, sir mentioned hysterectomy, timely hysterectomy. See, it is very important we are mainly working in a private nursing home with limited facilities. Not only the doctor is well versed with hysterectomy, his staff or her staff is also well versed with hysterectomy steps. So he will give that suture material, then instruments. So take the hysterectomy decision in time, right? It's difficult, but it is in time to save the life. Life is more important than uterus. In gynecology, you can discuss about save the uterus. Gynec patient is not in shock or emergency. Life is not at risk. Here, the life is at risk. You have many measures, but because there are small studies of all these, hysterectomy, sir mentioned a very large trials, and they are very well proved. And naturally, because you remove the organ, there is no question of bleeding. So, in proper time, one must do hysterectomy if required. Don't think of doing the procedure, trying the procedure which you have seen in webinar or videos, and then it will take time and may lead the patient to irreversible condition. So that is very important. And as somebody mentioned here, prophylactic, Alpesh mentioned, prophylactic uterine ligation we are practicing. Even if we are planning hysterectomy, sir has mentioned tourniquet, but we ligate uterine placenta acreta particularly, whatever hysterectomy 4 I have done, I have first ligated uterine and then proceed for hysterectomy steps. So that helps in somewhat control of the blood loss, right? And that obstetric ICU now, HDU, the Alpesh has very well done at central level also. So now facility available. Now drugs other than carbetocin, new recombinant factor, fibrinogen available, blood facilities available. All setup things have changed where we have practiced 20, 30 years back. It was saving a life was miracle for us that we were happy that we could save the life. Now the people are doing. And one more thing, hysterectomy for. See, people are not doing instrumental delivery because they have less skill and they go for cesarean section. So same thing, if you have less skill for other conservative measures, don't go for that, doing that one by one. You should do hysterectomy in time. I would not so straight away hysterectomy. right? Save the uterus, but not at the cost of life. Just my comments are this. Thank you.
Absolutely true, sir. I think save the uterus. We have to save the uterus, but save the life is also very important. So if we are unable to save the uterus, we have to save the life. So Dr. Parul, sir, if you want to say, and Dr. Sheila Mane, madam, Dr. Parag Biniwale.
I think Dr. Vinita, Dr. Shyam Desai again. We are eager because
let Shyam only do this.
He is doing a lot of good work at Suffolk. We all are.
Yes, sir. So
yeah. So you want me to talk on the case itself?
So we want final words from you. Final words.
Okay, final word. All right.
No, and I also wish all of you, all seniors, to tell me something about this, because this is something which should not go on as a message, that compression suture is a prophylactic measure, because they have sequelae. We have in Ahmedabad, Dr. Ajit Rabal, very senior colleague, he was routinely doing CHO suture in PPH. And he has found post-operatively, he did hysteroscope, and almost 1 out of 3 had adhesions inside the uterine cavity. So it's not an innocuous procedure. Life-saving is different. Prophylaxis is different. And prophylaxis, even uterine artery ligation has many. When we go on to academic discussion, it is not here we are talking of life-saving. Life-saving out of question, you do everything to save the life. But when you want to think about quality of life later on, things become different. And there you can use your judgment. But there is a beautiful article where uterine artery ligation, and they found that the placenta accreta rates increase significantly, because uterine is an end artery. And then the placenta, when the next pregnancy happens, has to go much deeper to get adequate. Every particular method is important, but decision has to be very deliberate. But I start with Shyam because he's the senior most, or Dr. Mandakini.
No, I want to make one comment. Is in one of the Foxy conferences, there was this doctor from Palakkad, that is Kerala. And he says, I've got a suction cannula, which I introduced, suppose there's heavy bleeding. It's not really amounting to PPH, but it's a sudden gush of blood. He says, I put this cannula into the uterine cavity and I attach a suction machine to it. And that cannula causes the entire uterus to collapse over it. And he says, I've treated several cases of PPH and I'm very happy with it. So there is a doctor, Dr. Karthik Bhagat, I'm sure many of you must be knowing him. He's been using this now for many years. And he says it's really nice because if there's a slight extra bleeding that happens after the delivery, maybe the uterus, the placenta being slightly in the lower segment, he says this particular cannula immediately arrests that sort of bleeding. So maybe we can even do a trial of this for PPH in our Foxy. One of ICOG can take up this as a method of trying to reduce PPH.
I agree with you, Dr. Shyam Desai.
Yes, there are two such this Samarthram, Esram, and Panikkar cannula. And we have used it. He has donated. We called Samarthram at our medical college in a workshop, and he donated one set of. Then we used in 8 cases, and in 7 it was successful. In 1 we had to go for further surgical management.
Madhima?
Parul.
Can I just say something?
Yeah. You will give the vote of thanks. Okay.
Yeah.
Yes, madam.
Can I say
please.
something?
Yes, madam.
Yeah. I think shown us the example, that how the courageous decision, and those days when you don't have the blood and blood products available. So we have to look at it that they gave 6, I think whole blood must have been given,
whole blood.
And 2 PRBCs. So those days, no FFP available. So the patient must have got clotting factors. But the quick decision, and in spite of the patient being in a shock, has saved the patient. And you really need courage, to do that. And in spite of that, he said that there was a edema and there was a ligature slip and bleeding. So, you have to really inspect everything. Now, coming to regarding the compression suture, I mean, as we are really now working for that evidence-based recommendation also, and we have gone through the studies. The studies say that when we have applied the compression suture, that is indicated in case of upper segment atonic postpartum hemorrhage. Additionally, there is no need to do uterine artery ligation. I mean, if it is not controlled, you go for stepwise, that is different. But together, there is no indication, only compression suture in cases of atonic PPH. If all other methods have failed, and we call it as a refractory postpartum hemorrhage, where surgical treatment is required in atonic PPH, we go for compression. But prophylactically, there is no role of any compression suture, and uterine artery extra is not required unless and until it is indicated. And as everybody told about Dr. Shyam Desai, I must also tell you that he has made me more active in FOXI. During his year, I think I have done many workshops on program labor. He himself came to Bangalore and really learned a lot from him. So thank you for this opportunity. Thank you.
Thank you, sir. Thank you, Sheila Madam. Thank you, everyone, for such a wonderful interactive session we had. Yeah.
Vinita,
hello?
just a
Yes,
minute.
yes. Okay.
Yes, Dr.
There is a huge need of training of even the PG passed postgraduate who are newly passed for this obstetric, dealing with all this. Because wherever we take a training, practical training, theoretical training for the, internal iliac ligation, there is a, great presence of all these newcomers. So I think ICOG also should think about having a capsulated training program for this, emergency procedures. Just talking will not help. So I say to request to Dr. Parul, internal iliac ligation, practical workshops, in anatomy lab that are proving very, very beneficial. We as a ICOG training body or teaching body, we must also look at this particular aspect of teaching and training in this particular emergency obstetrics. That is my recommendation.
Ma'am, it's a very good
Yes,
suggestion.
yes.
Dr. Shyam
Yes,
also
yes,
said
yes.
in the very beginning,
so-
he said that PGs should be more encouraged because that is the requirement of those, like the postgraduates. If they learn at their time these type of working, then only we can think of it that the incidence of mortality will be reduced.
Normally 2 to 3 days courses. Sheila Mane is there. So many people are there. And it
some
will be
more, yes.
wonderful. Wonderful. Thank
Yes,
you.
madam. So that's really very true. We should have training and I request Dr. Parul Kotawala to have some training, they should get some training. So it was really a very good interactive session we have. And thank you very much, Dr. Shyam Desai, sir, for giving us time for this, wonderful program. And at last, I would like to ask for the vote of thanks, our ICOG secretary, very dynamic ICOG secretary, Dr. Sarita Bhalerao, ma'am. So Dr. Sarita Bhalerao, she will propose vote of thanks.
Before that, Vinita, we all three experts are also thankful to ICOG, team ICOG, Dr. Parul Bhai, Dr. Sarita, and both of you. And of course, Dr. Shyam Desai, sir, we all have learned a lot from him. And today also we learn a lot from him, how to present a case. You have, sir, nicely presented the case. It's so much learning from you.
With so
Thank you
many
very much for
evidences.
giving us this opportunity.
Pleasure to interact with all of you. Extremely happy to interact with all of you.
Dr. Sarita, you are here.
Dr.
Just
Sarita.
to add,
Yes, Parul.
before Sarita proposes vote of thanks, I agree that we need to have a training module and we can develop that, but that would be surgical training. But PPH bundle approach is already there for the
Yes, madam.
medical
You have
part.
to put vote of
Parul
thanks.
Bhai, you can
We
think
have
of
in
PPH
India
course.
many
Dr.
innovations. Yeah. Okay, but in India, we have many contributions to handle PPH. Dr. Shivkar developed a beautiful concept of compression balloon. Then there is an indigenous balloon being developed in I think it was in somewhere in Raipur or that area.
In
Then
Chhattisgarh, Dr.
from
Nagini has
Kerala.
also
Karma,
So if we collect all this, then we will have then okay, this suture which combines both. Otherwise, we were doing separately uterine artery ligation and compression. So this concept of in single suture, both the techniques can be implemented. All this can be collected, collated, and I think let us do it from ICOG platform. That what is contribution of all colleagues in PPH in India. I think that would be a good document for people to follow up. But training program, we will have to think very hard because internal iliac ligation training is little bit tricky. Many times I am asked that question that at hysterectomy, why don't you teach us? See, internal iliac artery, again, I am talking of academics. When you ligate internal iliac, there are sufficient collaterals to provide sufficient blood supply to uterus at this point of time. But they reduce the capacity of that pelvic blood vasculature to handle an extraordinary emergency. By chance, a pelvic malignancy. And if she requires radiation, she will not be able to handle the radiation. So we cannot just do it right and left as a training. But yes, on a live patient, what we can do is maximum location dissection, not actually ligating. That way we can, and obstetric case is different than gynec case. So a person learning at a hysterectomy may not feel comfortable doing it at an obstetric situation. So there are many issues here which are minute. On the face of it, we do not realize it, but when we actually put it in, then we realize it. I think that's about all, and thank you all very much. And I hope that this series will go on with beautiful call. Sarita.
Yes, so Dr. Sarita
Last request.
is busy.
Last request, madam.
Yes.
I take this opportunity to request all of you who have logged in to give me vote, first blessings and wishes, and then vote for ICOG Vice Chairperson. I'm contesting. Thank you all. Thank you.
Sure, sir. All the best.
Thank you.
Yes, so Dr. Sarita Bhalerao, she is busy with some, webinar. So I request Dr. Kiran Pandey, she will give the vote of thanks.
Okay, otherwise Parag can also, okay, Kiran is fine.
Thank you, Dr. Vinita. Thank you, Dr. Parul. Already, I think, Dr. Parul, you have given very good inputs, academic things, queries to or points to ponder to us, all of us, about the training programs and all that. So let's hope something will come out, and the idea of bringing all the innovations at one place is also very good. Sir, we had done a PPH workshop in www.netcon, and there I tried to put many innovations. Even Dr. Panikkar had come. So that's really a good idea. Everybody knows of our Indian people working hard to save the women's life. With these words, I would like to thank the honored, esteemed Dr. Shyam Desai, sir, as a very eminent speaker. He, as Dr. Alpesh has said, not only presented a case, but also showed us the way how he presented with so many evidences from all the parts of the world, and proving the points with the evidence-based things. So that's where we learned a lot about from the interactions and the comments from the Dr. Alpesh Gandhi, Dr. Mandakini Meg, Dr. Hari Doshi, and Dr. Sheila Mane. So thank you, all the experts. Thank you, Dr. Parul, for giving us this opportunity. Thank you, Vinita, to be with us. Together, we have been able to coordinate, and we wish continue with these programs. So I just all the participants also, thanks very much, and let's request the other participants from in the future that they should spread these message of this case to their societies and many societies, so that we can have more and more people benefited by this. So I
you.
hope so. Once again, thank you very much, sir.
Thank you.
Thank you very much.
Thank you. Thank you.
Thank you. Thank you.
Thank you.
Thank you, Nilima also. She's a great help coordinating everything and providing all the information. Nilima, thank you on a personal note also.
And at last, I would like to thank all participants making this program a grand success. So thank you once again. Thank you very much on behalf of ICOG. Thank you very much.
So if Dr. Parul permits, we can close the
Please.
webinar.
Can
Okay,
we?
thank you.
I see
Thank you,
Manish's
Doctor.
hand raised, like, let us now close. Yeah.
Thank you.
Okay.
Okay, sir. Nilima, please close.